I'm Caroline Love. I am a doctor, but I'm not an ENT doctor. However, we often talk about reflux in the chest and reflux in its effect on the esophagus and everywhere else. So, and although this is probably a more minor set of issues, I figure that people may not recognise that they have it because they're so used to it, or they may have had these issues and not realised that reflux is the cause of it. Although I'm not an ENT doctor, I have had most of these problems, so I've got lived experience, if nothing else. What else? Next slide, please. I thought this summed up the issue with reflux and TOFS pretty well, that reflux isn't one damn thing after another, it's one damn thing over and over. Next slide. Obviously, Professor Maurice has gone through a lot of the issues with reflux and how we get reflux. So I'm not going to go over a lot of that again. I will go over the reasons that TOFs get more reflux or more problems with reflux than other people, although Professor Maurice has covered some of these. The first is that repair of the esophagus at birth can bring the stomach into the chest and can disrupt the ring of muscle that's there, and that can aggravate reflux and prevent that from shutting. The muscles that contract in the head and from the top of the esophagus down to the bottom don't necessarily work that well because the nerves are disrupted. Some of us have unsafe swallows and choke frequently when eating. Obviously, some of that is reflux, but some of it is that we also don't have great swallows in the first place. Let's see. Food can hang around because the muscles aren't working properly in the esophagus. I call it kind of being waterlogged, that when I've drunk too much fluids, I can feel a kind of wave of water here. And obviously, if that's sitting there, it can get back up into your head and neck and your chest and everywhere else, as Professor Maurice was talking about. TOFs are prone to stickies and to strictures, and both of those can increase the problems of reflux because then food just sits above it and comes back up. People with gastric pull-ups, as Juliet was talking about earlier, the stomach sat just under the neck, and then that easily tips up into the throat and into the chest and causes more problems. And as Professor Maurice was talking about with colonic interpositions, then they get tortuous and baggy, and then that collects pools of fluid that can then tip up into the head and neck. Could I get the... So what are the causes of laryngopharyngeal reflux? So the acid from the reflux and pepsin from the reflux irritates the lining of the throat. Now, pepsin is a chemical that's found in the stomach that helps break down food. But what it likes to do is sneak up in the reflux and stick to the back of the throat like a sleeper agent. And then when we get acidic food and drink into the throat, it recreates the stomach, the acid in the stomach, and then burns holes in the back of your throat. So you'll notice that when you eat or drink, then you get a burning sensation, then it's the pepsin that's to blame. The reflux also damages the clearing mechanism of the throat, which is why you get the mucus hanging around as well. How do I know if I have reflux? Now, I'm referring to it as laryngopharyngeal reflux, which Professor Maurice was obviously dissing earlier, but I'm going to stick with that because that's what's on the slide. It is what it is. Silent reflux, it's more silent in us than others because we've had it since we were born, so we don't necessarily notice all these symptoms. However, a lot of us have hoarse or croaky voices, particularly in the morning, difficulty shouting, using the phone, using Bluetooth. I can't use my phone in my car because it's just too hard on my voice. Constantly clearing the throat, the burning sensation in the throat, a sore and sensitive throat. The other thing people get is feelings of a lump in the throat all the time. Excess mucus in the throat and postnasal drip, which is stuff running down the back of your nose into your throat, which can also make you choke, which is additionally great. Bad breath is another issue with it. How is it investigated? Well, your GP may not investigate it. He may just diagnose it from the symptoms and crack on with treatment. But if it's not responding to treatment, they may send you to see ENT. The ENT may look down your throat with a laryngoscope. Could we go to the next slide? This video should play here, hopefully. So this is what it looks like in the throat. You can see the throat, this bit here shouldn't be this swollen. So basically this whole lot is incredibly swollen and red. And this is what you see when you've got laryngopharyngeal reflux. I'm not sure there's much else. Yeah, next slide, please. So on the video, on this picture, you can see, again, it's all quite red and swollen. This shouldn't be this thickened and sore. And this is basically thickened up a bit like your shoes, your feet get calluses on. So in response to acid and irritation, the vocal cords have thickened up as well. And this is the mucus that's hanging around. I know it's not a lovely thing to look at, but at least you know what's going on in your throat when you can feel it now. Next slide, please. So what makes it worse? Well, apart from being a TOF, there are a number of things that make it worse. Smoking obviously gets a lot of criticism for a lot of different things. Alcohol can make it worse. Spicy and acidic foods, obesity and bending over from the waist. So you need to bend from your knees really, and no gymnastics, I'm afraid. Next slide, please. There are some lifestyle, you would first manage it with lifestyle changes, so weight loss, stopping smoking, bending from the knees rather than the bending straight over, spacing your meals, particularly trying to avoid eating for 3 hours before bedtime so that that's not going to just come straight back in your throat and sit there while you're in bed when you lie down. Raising the head of the bed, and obviously that's partly what we're doing in the working group as well, looking for tips to try and minimise these problems. Now, Professor Maurice has already gone through a lot of the medical treatment, and obviously he's not a big fan of PPIs for the acid, but he's talked about other treatments for reflux. Alginates, so Gaviscon is a big issue, is a big treatment for throat reflux because it neutralises the acid. So you take it after each meal, and you don't drink or eat or even brush your teeth after it, because anything you do after you've taken the Gaviscon will set off the sleeper agent pepsin again, and it'll start breaking down the tissues in your throat. So you have to give it, you have to treat it harshly and make sure that pepsin doesn't get started. If that doesn't work, then Montelukast, which Professor Maurice mentioned, is another option, and surgery for reflux as well, which we all know about from previous things. I won't go into that too much. Next slide, please. So I'm going to quickly whiz through these. These aren't actually caused by reflux, but they can be aggravated by it. Next slide. So here you can see that the reflux, and usually laryngeal granulomas are usually caused by intubation, but reflux can aggravate it. So you can see that being attacked by a NG tube, or not an NG tube, an endotracheal tube, has caused a big lump here. Next slide, please. Vocal cord polyps. This is usually from abusing your voice, so shouting, particularly if you're a teacher or doing a lot of singing. And a bit like your feet, your vocal cords are trying to protect themselves and respond by thickening up and growing these polyps. However, what that does is leave you with an even more voice problems, so your voice giving way, difficulty forcing your words out, weak voice, hoarseness and breathiness, and pain on swallowing. With these two, I'm going to quickly say you can have voice therapy, which obviously Professor Maurice doesn't really believe in either, but you can also have surgery to remove these. Next slide, please. Laryngeal stenosis, this is caused by long-term placements of an endotracheal tube. So if you're intubated in the NICU or in the ITU, you can get sort of scarring and tightening, basically a stricture of your throat here. It's not caused by reflux, but the reflux makes it a heck of a lot worse. Next one. Now, I've mentioned this briefly. Reflux is implicated in laryngeal carcinomas. Now, smoking, chemicals, human papillomavirus, pollution, asbestos have a lot more to blame for this, but it is another factor. And last but not least, next slide. Laryngomalacia. This is a weakness of the throat, a bit like tracheomalacia. It's associated with TOF anyway. People usually grow out of it in infancy, but if it does persist, and even in infancy, reflux can make it worse. Next slide. So moving on to the nose and sinuses, this is defined as chronic inflammation of these areas for at least 12 weeks. Reflux can come up into the head, into the nose and the sinuses. Again, it causes irritation, causes swelling of the tissues, and then it can cause all the symptoms you get. There are other factors, so a lot of people will get it with hay fever. Smokers tend to get it. Pollution tends to be a problem as well. And some genetic diseases also make you more likely to get it. Next slide, please. So what symptoms do you get with it? So we've all probably had this to some extent, for different reasons. Blocked nose and stuffiness, runny nose, postnasal drip, which I mentioned before, the mucus running down the back of the throat, loss of a sense of smell if your nose is blocked, and that can affect your taste as well. If your nose is blocked, that can affect your sleep. And it can also give you sneezing, cough, bad breath again. Your sinuses, you get facial fullness, you can get pain on bending over, you can get a nasty taste in your mouth when the pus in your sinuses runs down into your throat while you're bending over, which is a lovely thought. Next slide, please. So investigations, again, your GP may not do this and may just diagnose it on seeing you alone. He may have a look up your nose and he may see that your nose looks a bit red and swollen. He may have a prod round your face and see that your face is looking puffy. He may see that when he presses you, your face hurts. If he does send you to see an ENT, then when you look up the nose with a nasoscope, you can see here that these big lumps here shouldn't be here. The lining of your nose would have really swollen up, and that's why your nose is getting blocked, because if you've got these big chaps blocking your nose, then obviously not much breathing is going to get through them. Let's see. Yeah, next slide, please. If the treatment hasn't worked, then they may do x-rays, and you probably can't tell particularly here, but I'll show you. Up here you can see pus and fluid hanging around in the sinus, and this bit here shouldn't be this thick. This is where all the lining of the nose and the bone is thickened up here due to chronic sinusitis. Next slide. And then this best way to investigate this is CT, and you can see here that this sinus here is just totally blocked with fluid, and there's also thickening of this lining as well. So that's what it looks like inside if you've got chronic sinusitis. Next slide, please. So yeah, how do we treat this? We always want to control the triggering factors, so if you are smoking, then you need to stop that. Avoiding paints, perfumes and other irritants. You treat nasal allergy symptoms, so if you've also got hay fever, then you treat that, and managing underlying asthma, and managing the reflux. But the main aim of treating this is through various sprays and drops in the nose. So they really like to use nasal washes with saline, and this helps to moisturize the nasal tissues and clear out any bits of that are stuck inside the nose. And also, if you use this before other treatments like the steroids, it improves the way that they work. Steroid sprays are probably the mainstay of treatment for this. You use it for 3 months at a time, and what it does is reduce the pathway that leads to the inflammation. So although the reflux is setting off the swelling and soreness in the nose, the steroids damp that down again. Now, personally, I find the drops more successful, but the GPs aren't particularly keen on giving those out. But they are given out sometimes for a week's course if you need them. The reason they're not too keen on them is that they can get more absorption into the body and thin the tissue, which is obviously not optimal. But on the other hand, they do actually help a lot more. So, Opticrom, which is sodium chromoglycate, that's used a lot in hay fever, but it can help in reflux-induced sinusitis and rhinitis as well, again by damping down the inflammation in the nose. Now, one thing that is very successful, but ENT and GPs don't love, is decongestants. They essentially clamp down the blood vessels in the nose, and then when you clamp down those blood vessels, the tissues shrink. So your nose unblocks really quickly. The problem with this, if you use them long term, then the tissues get used to it and start swelling up even more after you stop using them. So they kind of call it addiction. You're not actually addicted like you are to crack, but unfortunately, you're stuck with using it regularly, and it's really tricky to get off them. Next slide. So there are some medical treatments, so they will occasionally give you steroid tablets, particularly if you've got nasal polyps, but then there is a tablet, which, there is an injection which Professor Maurice mentioned for, well, reflux and for asthma and for eczema. It's used for lots of things, basically. It's not licensed by NICE for this use at the moment. I suspect that you'd have to jump through a lot of hoops to get it for rhinitis and sinusitis for us, so I doubt that we're going to get access to it. But I mentioned that it's there if it does eventually get licensed. And finally, if all else fails, then they may do some surgery. Surgery is about 85% successful, although that's mainly ENT surgeons love it. People outside of ENT are a little bit more sceptical, but because it does tend to come back a bit more than they claim. But they go in through the nose with an endoscope and cut away the thickened linings of the nose and sinuses. They also unblock the holes so the pus and mucus can drain, and basically you can breathe a bit more easier afterwards. Next slide, please. So I'll focus here on tonsils quickly. Adenoids swell up with reflux as well, but they tend to disappear in our teens, so we don't have to worry about them causing us too much trouble with reflux in adulthood. The tonsils are lumps of immune tissue that sit at the back of the throat, and it's what you get when you get tonsillitis, when they get infected. However, reflux can also cause them to swell up as well. That might not cause you any problems unless they start to interfere with your breathing, interfere with sleeping. And next slide, please. Oh, you can see here they're just massive here. You see always a little bit at the back of your throat, but they shouldn't look like big golf balls back there. So the problems you might get with these is difficulty breathing through your nose. You may find that your difficulty sleeping at night. You may get obstructive sleep apnea. So what that means is you're stopping breathing in the night, and then that leads to daytime sleepiness. Again, you might get bad breath because chronic changes in the hot tonsils can lead to tonsil stones, which can cause a really unpleasant smell and taste in the mouth, and you can get noisy breathing. Your GP will probably swab them to look for infection, but it's probably not infected. Treatment here is management of reflux, but if it is blocking your nose so much that you're getting sleep apnea, then they may be removed surgically. Next slide. Oh, sorry, carry on. I've whizzed through that by just pointing at things. Sorry about that. So Professor Maurice touched on this a little bit earlier. Reflux can cause trouble in the ears as well, that it can move up through. The eustachian tube connects the ear into the sinuses, and essentially it acts to drain the ear, and it also balances pressure in the ears. So when you go up in the aeroplane and your ears pop, that's what's responsible for that. It's basically allowing you to hear and your ears to function properly in a variety of different locations. When the reflux sneaks up the eustachian tube, like everywhere else, it causes the tissues there to swell up, and it also stops the tissues draining. The other problem that can sometimes cause this is that because the tube drains into your sinuses, if the sinuses are blocked, then it can't drain into that. So then that backs up and causes more problems. Next slide, please. So the main factors in this as well, allergy can add to this. It can be a problem in small children with allergy, which Professor Maurice mentioned. Symptom-wise, it may not cause you any problem, but it may cause centres of fullness in your ears. It may also cause your ears not to pop, and it can cause a loss of hearing, although not a massive loss, it's a little bit. It tends to be that when you've got sinusitis and those are blocked, then you get back up and then your ears go as well. Management, you tend to treat the sinusitis rather than the ears. But nasal steroids and anti-reflux treatment should help settle this as well. However, the other problem that it can cause is that if the mucus is hanging around the ears, then infection can get in there as well. If you keep getting repeated infections, then that can damage your hearing and damage the bones in your ear, and in which case they might do surgery on that. Next slide, please. So lastly, the teeth. So why does reflux damage your teeth? Well, enamel goes around each tooth, and it's a hard casing to protect the nerves and the blood supply to the teeth. We all have that. However, if you're very poorly as children, that enamel might not form properly. So TOFS, although it usually only affects your milk teeth, TOFS may be on a loser to start with if your enamel hasn't formed properly. Yeah. However, acid reflux comes into your mouth and it basically wears your teeth away. Essentially in the same way that acid rain will wear away statues, reflux is wearing away at the back of your teeth. It's wearing away at the molars. It can wear away at all of your teeth, but the back of your teeth and the top of your molars get it first. Next slide, please. So what you'll see if that's the case, you'll notice the first sign when the enamel's wearing away is your teeth look a bit glassy. So they're not the classic turkey teeth. They're not white. They're a little bit too shiny and not quite as white as you like them. Next slide, please. Oops, sorry. Yeah, sorry. The next step would be when the enamel goes, you wear away to the next layer, which is the dentine. And you can see here that there's the yellow dentine exposed, and also here. So, and also you can see in this one that the teeth are quite stubby, so more than just the dentine's been worn away. Next slide. Yeah, so after that you get chipping of the teeth, you get tooth loss. Your teeth can be worn to nubs, depending on the severity of the reflux. And whether any preventative measures has been put in place. Yeah, you can. Oh, sorry, it's all right. So how do we prevent this? Well, ideally, when we were having our second set of teeth grown in, then our dentist might have noticed this and put some fissure bonding on this. For those of us that are young and still getting our wisdom teeth, then when these come through, then I'd advise you to get those fissure bonded, because that puts an extra layer of protection against this wearing away on your teeth. Toothbrushing is obviously very important, particularly with an electric toothbrush. I don't know about other people, but I can't use an electric toothbrush because of oral aversion. Even the sight of it makes me feel a bit sick, but that might just be me. But using a fluoride toothbrush, fluoride toothpaste as well as an electric toothbrush, sugar-free chewing gum to promote saliva, chewing of antacids, again, neutralises the mouth content and promotes saliva. Occlusal shields, which I hadn't actually heard about till I was researching this, which you can see here. You can wear, those can be fitted by a dentist and can protect the top layer of molars, the molars and the layer here from being worn away by acid. Lifestyle measures, ideally we'd all be avoiding fizzy drinks and acidic drinks. If you're not avoiding them, then you should wait half an hour at least after drinking them before brushing your teeth, because otherwise when you drink these drinks it weakens the enamel and you're just brushing the enamel away when you do it too quickly. If you are eating acidic food and drink, then washing, using a bicarbonate of soda containing mouthwash and a fluoride containing mouthwash will neutralise that, and a fluoride containing toothpaste. Active treatments for actively eroded teeth that are just on the beginning stage, you can use dentine bonding agents. For more advanced changes to the teeth, the porcelain veneers that you get, obviously you get these quite cheaply in Turkey, but I can't recommend that. Particularly for those of us who are wanting to go on Love Island. And then finally you can get crowns, bridges and big reconstructions, depending on how severe the changes are. But that's it. Any questions?
I've got one question, and it's really great to see this because that means I can take stuff back to my dentist as well. I've been getting hygiene appointments every 3 months because it's the only way to stop the build-up of plaque getting worse, is what it is. And it took a lot of convincing them. They kept going, brushing your teeth properly, and I kept saying, I've got to get to toothbrush, I've had braces before, blah, blah, blah. So been doing that, but what it means is, because the hygiene appointments you have to pay for them. So it means so my question is there a way around that because we have this very severe issue with the reflux, how we get around that in terms when it comes to dental treatment?
I suspect we're stuck within the vagaries of the NHS and non-NHS appointment systems for dentists. I'm not sure there's much we can do to avoid paying for it, unfortunately. Possibly your GP could write in support of that it is due to a medical condition that's causing the dental changes, which may mean that you get extra appointments on the NHS system for free, or your other respiratory physicians and things could write supporting statements to that effect, which would be what I would do as a first line. I mean, we could also you could also take along the adult handbook to the dentist and show them that it's part of it as well.
I was just wondering in terms of like a timeline, because I've had like a worsening of sort of stomach issues in the last few years, and as far as I'm aware, my teeth are still okay, but it is a bit of a worry. I didn't know how long to expect before things might go downhill, and I might need to be more aware of things.
I think if your teeth are okay at the moment, what I would do is talk to your dentist and talk about fissure sealing your teeth if they've not already been done, because if you are getting some reflux symptoms, then chances are your teeth are going to get worn down. I've been relatively lucky with my teeth. I've had a reasonable amount of cavities, but I think my teeth are a bit glassy. But it is very variable. Some people will have a lot of dental loss, and some people won't. So I can't give an exact timeline, but I think the key thing here is to be proactive and to get them sealed if you can, because that will really stand in the way of a lot of the damage, particularly the back of your teeth. I've had the back of my teeth filled for that reason. They tried to claim it was some kind of genetic anomaly, but having researched for the TOF book, it was clearly reflux all along, but I didn't know till that point. Well, to be honest, I did suspect even then it was reflux, and I thought they were talking nonsense. I just didn't have the information to back it up.